this APOC study, which we've run in the state of great state of New South Wales over the last 8 years or so, and really focusing down on treatment. Professor Rhoda and Suzanne will give you a bit about the risk factors and early parts of breast cancer diagnosis, and I'm really focusing on treatment today. The first part of the study, really, we're looking at a population-based study where we got records from the New South Wales Cancer Registry, linked them with the New South Wales hospital records to try and find out about surgical treatment in particular, because that's mainly done in hospitals, and also with death records to look at survival. Just for a rough idea of how many people are involved in this, there's about 30,000 non-Aboriginal people, non-Aboriginal women in this study, and about 300 Aboriginal women. This data was recently published in the BMC Cancer Journal earlier this year, and that's the reference there if you want to look it up. Sorry, I can't quite see that. But yeah, so what we found, similar to what the results were there that were shown earlier, is that Aboriginal women in New South Wales diagnosed with breast cancer compared to non-Aboriginal women. They were slightly younger at diagnosis and had a slightly more advanced spread of disease at diagnosis. They had surgery at a similar rate to non-Aboriginal women, but it was just marginally insignificant or significant, depending on which side of the fence you go. And at a similar time after diagnosis. So the gap between diagnosis and treatment was quite small, around about 14 to 15 days usually on average. They were more likely though to have a mastectomy compared to non-Aboriginal women. So that may be a function also of distance, in the sense that women would choose to have a mastectomy so they don't have to come back for radiotherapy or chemotherapy. And they're also more likely, as said, to have comorbidities such as diabetes or cardiovascular disease at the time of diagnosis. If you look at mortality for women in New South Wales, we see this interesting pattern where after 5 years, Aboriginal women, in the sort of dotted line at the top, they're about 50% more likely to die from their breast cancer after 5 years, compared to non-Aboriginal women in the sort of solid line. The interesting part about this diagram, though, is if you look at the first 18 months or so of the, I don't want to press the button, but I'll get close here. This sort of first 18-month period here, the survival is actually identical for Aboriginal and non-Aboriginal women, and then it splits after that to 5 years. And that really is, when I look at that graph, and maybe other people in this graph, in this crowd will think, it's an indication of good early treatment, such as surgery, as we've seen, and then perhaps lesser uptake or receipt of adjuvant therapy, such as chemotherapy and radiotherapy and hormone therapy after that time frame. When we tried to look at differences in surgery, we did a little statistical modelling exercise, and we found that Aboriginal women in general had 40% lower odds of getting surgery within 12 months of their diagnosis. We tried to adjust for this statistically by adding in variables about age of diagnosis and year of diagnosis, so things that are really patient factors. Looked at then again at spread of disease, and you see the gap's actually widening a little bit. But then when we add in things like place of residence, comorbidities, and socioeconomic disadvantage, we're really back to the beginning. So this is the odds ratio between Aboriginal women and non-Aboriginal women who had surgery, and really after doing all this fancy statistical stuff, we explain pretty much nothing. So really those things in New South Wales at least didn't explain the gap in surgery that we saw. And this is the gap here. Here we have, you can see here, most people, this is the time to surgery after diagnosis. You can see here, most people are getting their surgery, 50% of them getting within less than half a month, about 15 days. And after a month, 31 days, you've got almost 80% of people having surgery. And then little bits of, along the way up until almost a year there. You can see there's a gap at the end, again with Aboriginal women in the yellow, about 85% of them receiving surgery after diagnosis, within 12 months of diagnosis, compared to almost 90% of non-Aboriginal women. So really the end of our modelling and all our our statistical enterprises in doing this paper, we found that really that survival, while lower for Aboriginal women, it could partially be explained by differences in age and spread of disease, distance, socioeconomic status, but really most of the difference when we did our modelling was due to comorbidities and differences in surgical treatment. Okay. So the second part of the study we did, it's not a linkage study, what we did is we went to actually 23 major hospitals in New South Wales and 3 what they call clinical cancer registries. We got medical records for 1,300 Aboriginal women, or Aboriginal people, sorry, and diagnosed within the years 2000 2011, and of those there are 193 women with breast cancer. And we were able to therefore, because with the population data, we could really only get data on surgery. This now looked at the other end. So after your surgery, we got a little bit more details on surgery, but mainly we were looking at things like what sort of radiotherapy, chemotherapy and hormone therapy people got after their surgery. And this is very early data, first time anyone's seen it, first time I've seen it, but I hope it just gives you a flavour of what we can do with the data. So this is the data. These are from the 193 women that we got from the hospitals. And you can see here, as you might imagine, because we only got women from hospitals, we didn't get the whole population, so we've slightly biased towards people who actually got some sort of treatment. So in fact, in this case, 90% of women actually got surgery compared to 85% in the population. And you can see here that just over half of them got radiotherapy. Again, about half got chemotherapy and half got hormone therapy. So I was hoping to put another column there comparing this to the non-Aboriginal population so you can have an idea of what it is. But in fact, the data doesn't exist. I went looking around and we couldn't find any for New South Wales. But if there's people in this room who know about that, who have an understanding of it, please come see me afterwards. I'd really love to know about it. But certainly, yeah, it was hard to find the data. Best we could do is find some data from Western Australia, and we were roughly in the same ballpark as the Western Australia data for non-Aboriginal women in terms of getting those treatments. If you look at receipt of these therapies by remoteness, I know that's been mentioned already today, but you can see sort of patterns that you might expect. On the very far left there, your left, yes, you can see here the red bar is radiotherapy, higher rates of radiotherapy going down as we go further away from major cities. As we know, most radiotherapy clinics are situated in large metropolitan centres or large country areas. Surgery slightly goes up as we go across in the blue from major cities to remoter areas. And chemotherapy and hormone therapy stay about the same across the whole spectrum. Whoops, sorry. And that's because they're largely not location dependent, and it's sort of what you expect. Chemotherapy and hormone therapy can be delivered outside of a major teaching hospital. And then I guess the other thing I tried to look at was really about treatments received by spread disease, to see whether, whilst we don't know what the overall population is, at least see if it's roughly in line with what guidelines might tell us. You can see here that we have very high, for women who have localised or regional disease. This is just Aboriginal women again, so just localised and regional. We've only got 173 of those. Very high rates of surgery, radiotherapy, as you might expect, slightly higher in the regional spread of disease women. Chemotherapy also a little bit higher in those groups, actually quite a bit higher, and hormone therapy about the same for regional and localised. So I guess that sort of says to me that if you're an Aboriginal person or even a non-Aboriginal person, if you can get to hospital, then you get pretty good treatment. Okay, you're going to get reasonable amounts of care, as best we can guess from what the published data are. There may be other data out there that I'm not aware of, but yeah, it'd be really great to know about that. And the surgery, chemotherapy and hormone therapy rates don't vary a lot by remoteness. They do go up and down a little bit, but radiotherapy seems to be the one that varies the most, and that's mainly, of course, because the major radiotherapy centres are all in major cities or in the regional areas. That's just a couple of references for people to look at afterwards if they're interested in checking up on me. And thank you very much.